Hello everyone, Fatima, Kamal, Michael, Nada, how are you all? Anju, Fadi, Fatima, yes, my dear.
Fine, ma'am. How are you, ma'am?
Yes, I'm good. How's preparation going on?
Yes, ma'am. Going, ma'am.
Okay, any volunteer to present today case?
Ma'am, I can
Anyone?
present, ma'am. Ma'am, I can present,
Okay,
ma'am.
yes. Dr. Fatima, right?
Yes, ma'am.
Okay, my dear. So this is Dr. Gauri with you all. I am one of the senior mentors from RFA group. Okay, so
Yes, ma'am.
today, just this one case. I will be your examiner today. Okay. So it will be 2 minute reading time and then after that 10 minutes case time. Okay. And after that we will discuss the key of the case scenario. And if anyone is having any doubt related to the topic, we can discuss accordingly. So shall I start your 2 minute, my dear?
Yes.
Yes, please. Just a minute. Yes, 2 minutes.
Ma'am, next slide, please. Ma'am, any more slides?
No, next is question slide, my dear.
Okay, ma'am. Can I start, ma'am?
Yes, 10 minutes. Yeah,
Yes,
start,
ma'am.
please.
Hello, I'm Dr. Fatima. I'm one of the candidate in the exam today. I read my scenario and I'm ready for structured discussion.
Okay, Fatima, so you have this case scenario in front of you, and your first question is tell me what further information do you want to know from this patient?
Ma'am, I want to know the detailed history of the patient.
Mhm.
About is it a first pregnancy or do she is having more children before? She is having any history of any liver diseases in the past? I would like to know her like menstrual history. How is her periods and everything? Any problem in that? About the pregnancy? Any problem in the pregnancy? Any hyperemesis gravidarum in the first trimester? And any liver disease, any yellow urine passage, any palms and soles, any pruritus, and in the body, any patches or any skin lesions there. And I would like to ask some intrusive question that she is having any sexually transmitted infection or any infection like viral hepatitis. Has she undergo any investigation for uh, for this condition, and since how long she is having this problem of anorexia, abdominal pain, nausea, vomiting, and she having headache, any protein in the urine, any blurring in vision, like that, any time any the bp rises, she is having her OGTT test done or not, she is having any medical illnesses like diabetes or hypertension, anything like that. I would like to have her investigation reports to be done. I would like to ask her past medical history to know about any medical illnesses, any surgeries, tummy or down below, any allergies, any her blood group, if she is RH negative or not, and if she is RH negative, she has taken the NTD or not, and her support at home, and any blood transfusion before. uh, I would like to ask if she smokes, drink alcohol, or take any recreational drugs. And in examination, I would like to examine her the baby heartbeat from tip to toe, like her or general in vitals are given. I would like to heart the baby fetal heart rate movement is okay or not, and to see if she is having any investigation like complete blood count, liver function test, renal function test, and her uric acid and mm, urine test to see bile acids in that, and bile salts, bilirubin, and I would do a quick ultrasound examination for her. I would like to ask her if she is having any pancreatic problems or something like that. Then I would, with all these investigations, I would like to admit the patient, and this all information I need, ma'am.
Okay, so based on your history, so tell me what is in your mind? What is your differential diagnosis?
Ma'am, it can be acute fatty liver of pregnancy. It can be a preeclampsia, HELP syndrome, obstetric cholestasis of pregnancy, and she can maybe a case of pancreatitis, autoimmune hepatitis, any viral hepatitis infection, like that, ma'am.
Okay, so based on your differential diagnosis, what investigation would you like to do for your patient?
Ma'am, all this test, urine test for protein, and
Mm-hmm.
CBC, liver function, renal function, and viral hepatitis panel, and I would like to
Mm-hmm.
do ultrasound, and if it's possible, MRI for the patient, and
Ultrasound for what?
ma'am, upper abdomen and all the organs, ma'am, and for the baby also, ma'am, to see if baby is low birth weight or
Okay,
something
so
like
these
that.
are the investigations. Go through that first.
Ma'am, this
So based
investigation.
on these, yeah, tell me.
Yes, ma'am.
Yes.
Based on this investigation, it is more chances is having acute fatty liver of pregnancy, because ultrasound is showing fatty liver appearance, clotting time is increased, creatinine is also increased. So that means it is having a renal involvement also in that, ma'am.
So
And
based on
ALT
these
and
labs
AST is
and
also ALT and AST
yes.
also raised, ma'am. So liver, that is surely a liver problem.
Okay. So based on these investigation, so is there any other investigation would you like to consider for your patient?
Mm.
No, sir.
Ma'am, MRI also, if possible. And CBC, ma'am.
Okay.
CBC is not there.
Okay.
Uh, and ma'am,
And
my
what is
most
your
like
most
most
likely
likely
diagnosis as you
diagnosis
mentioned?
acute fatty
Fatty
liver
liver
of
of
pregnancy.
pregnancy.
Yes,
So
ma'am.
now tell me, what are the criteria which will help in your diagnosis?
Ma'am, the criteria is called Stency criteria. It will
Mm-hmm.
have the symptoms like abdominal pain, nausea, vomiting, fatigue, anorexia, and
Mm-hmm.
investigations like ALT, AST increased, uric acid increased, clotting factor APT, APTT deranged, uric acid increased, and platelet and all those are normal. And
Mm-hmm.
sometimes it is having anemia also. And in
Mm-hmm.
liver USG, it is showing fatty liver of the liver, fatty concentrate deposits of in the livers.
So what do you think? According to this NC criteria, how many factors in this criteria which will help you to confirm the diagnosis?
Ma'am, 6 factors should be present for to confirm the diagnosis.
Okay, so now your patient is in front of you and you have seen the investigation. So tell me, what will be your immediate management in this case?
Ma'am, immediate management is to admit the patient mainly in the intensive care unit. We have to stabilize the patient, and delivery is the first and foremost thing. LACS section is not the indication for this patient, but as it is the fastest way to deliver, so it is considered. But if the bishops are fine, we can go to a normal vaginal delivery also, ma'am. But here we have to first give FFP or cryoprecipitate to the patient, and we will try for which anesthesia we have to give. There is an MDT, our consultant anesthetist and hematologist and hepatic gastroenterologist should be involved in all this. And we have to deliver the patient as soon as possible. We have to decide which anesthesia should be given, because if there is platelet less or clotting factor deficiency, we cannot give neural axial anesthesia, but with the help of the FFP and cryoprecipitate we can consider it. But if for general anesthesia, as the liver enzymes are also deranged, we cannot give this. NSAIDs and opioids, NSAIDs are contraindicated after the delivery, and opioids we have to give after taking into consideration that its metabolism decreases. And
Okay, so
uh,
now you have planned your delivery, your patient is delivered. And what postpartum care does she require?
Ma'am, postpartum intensive care unit she required to see her vitals every 4 hourly to 6 hourly, and we have to check her blood investigations daily or alternate day basis, and we have to look for the sign and symptoms of the patient. And as I told you that opioids can be given for painkillers, but with very caution, and antidote should be available with us, and NSAIDs are contraindicated. And if it is required, if any blood clotting or anything should be suspected, so LMWH can be given. CBC should be done, and if more required of the cryoprecipitate or FFP, we should be given like that thing also, ma'am. And baby care, nursing care, and early mobilization, these all things should included. uh,
Okay, your time over, but this is your last question. How will you counsel her about the prognosis?
Ma'am, I will tell her that she has having acute fatty liver of pregnancy. It is not a very simple problem. Like it is, I will breaking bad news will be there. I will tell if she has some partners with her. It is better. In this, maternal mortality should be very much high. So we have to act very fast, and we have to deliver the baby very fast. We try to save the baby and put it in the neonatal care. But a mother is more important for us, and we require to do the all the things, and we have to take care of the mother. And if as soon as we will try, and if it's not possible, if the mother is having acute kidney injury or liver problem, liver transplant also will be required in this case.
Okay, thank you, Fatima, my dear. Thank you so much. Your
Thank you,
time
ma'am. Thank you.
over. So
Thank you,
tell
ma'am.
me, how is your presentation? Do your
Ma'am,
reflection.
I tried, ma'am. because Dr. Sidra told me to present more and more, because I am weak in
Yes.
presentation and I'm weak in explaining, and especially BBN and all. So she said that I required more practice. That's why I prepared
Yeah.
this, and I.
Yeah, that is very good. I really appreciate that you prepared this case. You went through this TOG article. What are the new things in the TOG article? You have that knowledge. And yes, overall, you tried your best. You covered all the answers of the question. That is very good. Anything from your side? What do you think? Anything missed or anything which you need to explain in detail?
Ma'am, I think the more the question, what further investigation would you consider? I think I have not answered this well, and I don't know
Yes.
because I have think that I have covered whatever I know. I have covered all those things. It is already there in. I don't understand, ma'am, what further investigation would be there in this.
Okay.
So I didn't
Okay.
answer this
Got it.
question well, ma'am.
Okay. Got it. And last question. If I consider time, I will not give marks on that question, right?
Okay,
If I
ma'am.
consider your time management. Clear?
Yes, ma'am.
So, yes, overall, it was a good presentation, but today, as per the result of this last exam, okay, you all know this time result was very tough, okay. They mark each and everything of the key, and if any student even missed or two or three two or three points, I would say, in the applied clinical knowledge. This time they fail the student mostly in applied clinical knowledge. Okay. That's why we arranged these more sessions on the YouTube also to make aware with the students that nowadays they have to focus each and every point. Before we were also thinking, okay, if we consider MDT will manage, anesthetic will manage, and we can give answer in different way to cover the topic. But this time, as per the students' feedback, they were also mentioning that this time examiner want each and everything to be covered in detail, especially in patient safety point, apply clinical knowledge, and information gathering also. Even though they were focusing on to ask from the patient what work she is doing, like occupation also, in some of the stations, they consider that we should ask from the patient. Okay. So the take home message that we should have at this time proper knowledge on each topic, good amount of applied clinical knowledge and information gathering from A to Z depending upon the module you need to cover from the presenting complaint HOPI and rest of the history template depending upon the module. Like here we are in the maternal medicine. So here you covered all the points, blood group, preservation, any history of blood transfusion. Everything was good. And another point in the structure discussion, one point I want to say, in structure discussion, always remember whenever you people are asking, even though history, examination, and investigation. Structure discussion means you have to justify yourself. As you mentioned that you want to know vomiting, fits, blood pressure, but what is in your mind? So, whenever you mention, I would like to inquire about any history of high blood pressure during pregnancy to rule out preeclampsia and HELP syndrome. Okay, so this is my justification that why I want to know about blood pressure. You got my point, Dr. Fatima, Michael, Fadi.
Yes,
Everyone
ma'am.
agree on this point?
Yes.
Yes. Yes, ma'am.
So, a structured discussion always make the habit not only in the investigation but from the history. Justification is very important, like epigastric pain, vomiting, anorexia, history of jaundice, history of anemia. But why you want to know all these things? So you have to say because my differential diagnosis could be acute fatty liver of pregnancy, could be preeclampsia, could be anything related to the hepatic, like primary biliary cirrhosis, like pancreatitis. That's why I want to know these questions in detail from the patient. This is one thing. And as you see here, an investigation, prolonged PTA, PTT, so maybe there is underlying any bruising or any history of bleeding. And then rest of the history, if I would say, don't forget the baby. Your patient is 36 weeks. So obstetrical ultrasound, CTG also is part of investigation. In this case, maybe baby's IUFD, we don't know. Right, Fatima?
Yes, ma'am. Ma'am, you,
So yes,
ultrasound I have told, CTG I have forgot.
yes. Yeah, ultrasound, when specifically I asked you what ultrasound you want to do, then you mention about to check the baby and to check the upper abdomen. Okay. So
Yes,
this
ma'am.
thing should be, because here I prompt, but maybe in the exam, examiner will not prompt you. Okay.
Yes,
So
ma'am.
this is the thing. Diabetes, you mentioned. Differential diagnosis were okay. And history of fetal movement, you need to ask. Headache, you mentioned. Then differential diagnosis was okay. And yeah, one more thing in history. You said any after giving the signposting, I would inquire about sexually transmitted disease. Viral infection, I agree with you. Okay, hepatitis A, B, C, D, E, anything related to the liver, I agree. But is it okay to ask sexually transmitted disease in maternal medicine template without any risk factor?
No, ma'am.
If something in your mind, you have to justify. The only thing in the exam, if you want to do, you can do, but you have to justify yourself.
Ma'am,
What is in your mind?
I think hepatitis B I want to rule out because it may be a
Yeah, so
sexually
actually you can
transmitted.
say hepatitis B, C, both are related to the liver problem. A and E also related to the liver problem. That yes,
Bu-
I agree with you. And yeah, here you mentioned I would inquire about any history of surgery on the tummy or down below. These was your words.
Yes,
In
ma'am.
structured discussion, this is in simulated patient task, tummy or down
Okay.
below. Here, I'm your examiner. Okay. Any history of surgery, or you can say abdominal or vaginal.
Okay,
Okay.
ma'am.
No,
Yeah.
no tummy or down below. This is not simulated patient task. Okay.
Yes, ma'am.
And then you mention I would check fetal heart sound from tip to toe.
No,
I
ma'am.
don't know what does it
Fetal
mean.
heart. I mix two things. Firstly, I want to say I examine the patient from tip to toe and I will heard the fetal heart sound. That two I
It
have
is tip to
mixed.
toe or head to toe. I don't know.
Head to
Maybe tip
toe.
to toe is
Head to
also
toe.
head to toe.
Head to toe.
Right? Yeah. Because it was the new thing. I thought maybe anything in your mind. Okay. And one more thing, what I have written. Yes. You, in between, you mention I would inquire about history of like headache, visual problem,
I want to rule out
any.
preeclampsia, ma'am.
No, that is okay. That is okay. The way you speak, I am telling you. So many times you mention any word, any history of headache, any history of visual problem, any history of vomiting, any history of reduced fetal movement. So just I'm giving you in structured discussion, whenever we are giving answer, we should be more confident and in smooth way. Simply you would say, my differential diagnosis in this case, intrahepatic cholestasis of pregnancy, HELP syndrome, preeclampsia, acute fatty liver of pregnancy or HELP syndrome. Keeping this differential diagnosis, I would inquire further information about, go in one row, headache, visual problem, abdominal pain, anorexia, nausea, vomiting. Like that, you go in one row. Not say any. Okay?
Okay, okay, ma'am.
In between, you say everything, anything. So avoid these words only, I'm telling you. Okay?
Okay, ma'am.
Like something like that. These words you, because we have habit in routine also, we are mentioning these things in our routine practice whenever we are speaking with the patient or whenever we are speaking with the friends. We have such kind of habits, but in the exam we have to be careful. We have to go in one row in smooth way and complete your answer. Okay, this is one thing. Second, this you mentioned tummy or down below. Yeah. And don't use the abbreviation in the exam. As you mentioned here, LMWH, low molecular weight heparin. Okay.
Heparin.
Yeah. So heparin, you would say avoid abbreviation. And MDT you mentioned, but first you mentioned that I will offer the admission, then she need delivery. Delivery is the definitive treatment. Yes, I agree with you. But if you say here, what I told you, what is your immediate management? So our immediate action, as you mentioned that you will offer the admission in ICU or high dependency unit, you mentioned about urine output, IV line, cryoprecipitate, FFP, depending upon the anesthesia also you mentioned. But here I want you little bit to give the answer in more detail, immediate and then definitive. Immediate means first you need to stabilize your patient, right? And how will you
Yes, ma'am.
stabilize? As you mentioned, you will offer admission. This patient need to be treated with the MDT team, okay? In which
Okay,
we
ma'am.
will involve, then elaborate the name of your team member, obstetrician, anesthetist, neonatologist, ICU team, critical care team. Yeah, these are senior midwife, porter, because you need to send urgent investigation. You need to pass IV line. You then monitor the vitals of the patient, monitor the Meals chart, give analgesics, arrange FFP and cryoprecipitate. So this is your immediate management. Then definitive management, once my patient is stabilized, definitive treatment of acute fatty liver of pregnancy is delivery of the patient.
Delivery of
That
the
is depending
patient.
upon the Bishop score. Obstetrical, if there is no any obstetrical indication for cesarean section and with favorable Bishop score, we can start even induction of labor. Then you have to explain me how will you induce and in which criteria you will decide for cesarean section. As you mentioned, anesthesia, yes, neuraxial anesthesia is not safe. You can give because of risk of epidural if you want to give, but then yes, you have to consider to give cryoprecipitate or fresh frozen plasma. Here, if I would tell you what is the complication of neuraxial anesthesia in this case?
Hematoma formation, ma'am. And
Okay. And if your anesthetic consider to given even again this epidural, then what you consider? If I say either you will give cryoprecipitate or FFP.
cryoprecipitate, ma'am. Because
Why?
FFP will increase the uh, preload on the heart.
Yes. Okay. So this is as per the TOG article, we would
TOG
consider
article.
cryoprecipitate because FFP we need to give more volume, so risk of pulmonary edema and risk of afterload is there. Any and what is the indication of liver transplant?
Ma'am, if patient is not stabilized, patient is having the acute kidney injury and not settled by dialysis and plasmapheresis, and he's having pancreatitis not getting better, and liver is she's in liver failure and having all the parameters deranged.
Deranged and deteriorating. Good. And after how many days in the postpartum period would you think your patient will recover? How will you, as I mentioned here, how will you counsel her about the prognosis? So in this point, you have to explain that in how many weeks her labs and her condition would be recover completely, and in
Ma'am,
which case she need renal
ma'am,
this
symptoms.
liver transplant. Mhm.
Ma'am,
Tell me.
symptoms will be fine within 7 days, and the lab investigation will be fine within 6 weeks.
Okay, so this point we need to explain to the patient in the
Okay, ma'am.
counseling point. Okay. Otherwise, overall, it was a good presentation. But as I mentioned, these are the missing points.
Ma'am,
And
what further investigation would you consider, ma'am? What is the
I will
answer
show
for
you the
that?
slides. Yes, I will show you the slides now. So this was your first question. Duration, severity of symptoms, jaundice, pruritus, headache, visual problem, nausea, vomiting, reduced fetal movement, history of preeclampsia or any symptoms, itching. Itching will help to differentiate from intrahepatic cholestasis of pregnancy. Any history of bleeding or bruises to rule out the coagulopathy, polyuria or polydipsia to rule out the hypoglycemia or decay because maybe my patient would suffer from the diabetes. Drugs, alcohol, exposure to infection, this you mentioned, antenatal history. You can review the notes of the patient. Is it first time she is having these symptoms or any previous history of such kind of symptoms or any admission during the pregnancy? How is our pregnancy so far till now? So antenatal journey is also important in this case, right, Fatima?
Yes, ma'am.
Yeah, then past medical, any history of liver problem, especially, and any history of like preeclampsia or hypertension in the past, depending upon the parity. Surgical, social, family support, blood group, BMI is very important. And how is she feeling in nowadays, and what is her occupation? We need to add this point also. So your differential diagnosis, as you mentioned, acute fatty liver, HELP syndrome, preeclampsia, gallstone, ICP, pancreatitis. But here, in your case, when I showed you the investigation, hypoglycemia was there, hepatic dysfunction was there, renal impairment, which highly suggestive of fatty
Acute fatty
liver of
liver.
pregnancy. So these are your further investigation. Full blood count, we have to repeat the platelets. Liver function, we need to detail liver panel. Coagulation profile, PTA, PTT is there, but you want to check the fibrinogen. Serum glucose, you need to repeat because your patient is already having hypoglycemia when it was done, so I will repeat accordingly. ABGs, lactate, maybe there is underlying sepsis which we don't know. Blood cultures, you have the sepsis, group and save and cross match. If hemoglobin is low, clotting sample for transfusion. Obstetric and ultrasound CTG. Then your diagnosis was okay. You mentioned this criteria also, and as per the TOG article, six or more than six criteria which will help our diagnosis of acute fatty liver of pregnancy. So our patient is having abdominal pain, vomiting. She is having bilirubin high. She is having transaminase high. Uric acid was high. Coagulopathy was there. Creatinine was high. So all and imaging bright liver on the ultrasound. So here, out of these, our patient fit into the acute fatty liver of pregnancy. So your diagnosis was okay, and your immediate management. Here, I would say to mention these points first, then go you for the definitive management, that is delivery. So immediate, first of all, you would say, I will offer the admission to my patient. Her care should be with the multidisciplinary team unit, which include obstetrician, anesthetic, critical care team, hepatologist, and neonatologist. I will go through the ABC approach, admit into the high dependency unit, will pass to bowl IV line cannula and start the IV fluids, but I have to make sure to avoid fluid overload because of underlying any possibility of high blood pressure. Will treat the hypoglycemia. This is very important because your patient is having a low glucose. So we have to treat glucose with 10 to 20% dextrose infusion. Correct coagulopathy, as you mentioned, FFP, cryoprecipitate, and platelets if needed. Monitor hourly urine output, glucose, coagulation, electrolytes, and neurological status. So this all will be our immediate management. Immediate means immediately what you will do. Then if whenever examiner is asking you what is your management, then you can go in one row, A, B, C, D, E till delivery. But if examiner is asking you what is your immediate means first you have to stable the patient, whatever the case. For example, ectopic pregnancy, for example, ovarian torsion. So any case which is acute emergency or deteriorating of the investigation, patient is having symptoms. So what will be our immediate management? Like for example, if scenario is HELP syndrome, if scenario is eclampsia, first we have to stabilize the patient, right? By giving the antihypertensive and magnesium sulfate, stabilize, then only will go for the definitive management, that is delivery. So here, these are your immediate management, then followed by definitive. So definitive is urgent delivery, as you mentioned. So you can say once maternal stabilization is achieved, as per evidence, delivery within 7 days of onset of symptom is associated with 100% survival. But with the delay of even 2 weeks, survival will be up to 70%. So the definitive treatment in acute fatty liver of pregnancy of my patient is to deliver the patient by assessing the Bishop score. We'll go for induction of labor, cesarean section only if there is deterioration or failed induction. Involve anesthetic early, keep blood product ready depending upon the anesthesia as there is a risk of epidural hematoma. INR should be below 1.5. Okay. If fibrinogen low, then keep your cryoprecipitate ready. 15 gram of fibrinogen is preferred to FFP, which I asked you, as risk of overload result in heart failure. This is very important patient safety point. Risk of hemorrhage is there, so make sure your blood product is available. Continuous CTG monitoring. Senior obstetrician and anesthetic involved may manage the postpartum hemorrhage risk. Also, avoid NSAID you mentioned, avoid fluid overload you mentioned. If eclampsia risk is not clear or you're thinking patient is eclamptic or any other history of means high blood pressure, then you can consider magnesium sulfate if your diagnosis is confirmed. Otherwise, no need. Postpartum, as you mentioned, high dependency unit, LFT, clotting, renal function, glucose. Watch for encephalopathy, thromboprophylaxis once coagulation is normal. This is again very important point. Heparin we will give, but once our coagulation is normal and with involvement of hematologist. Psychological support is important. Counseling, maternal mortality risk is there, liver, kidney, and coagulation function. Usually recover within 3 to 4 days up to weeks, which we need to counsel the patient. Small risk of persistent renal dysfunction, acute liver failure, coagulopathy, GI bleeding is there. Liver transplant in patient with acute necrotizing pancreatitis that is not responsive or conservative management or plasma pheresis. So these cases will need liver transplant but should be in the higher center. Future pregnancy risk of recurrence is there. We have to counsel the patient about preconceptional counseling and early monitoring in the next pregnancy. So this is your overall key of this topic. If we go through the domain wise, your communication was good throughout your presentation. You mentioned that you will involve your patient, you will communicate with the patient, and your eye to eye contact with the examiner also was there. So overall, I would say your communication was passing. Information gathering, overall it was good, but antenatal journey points was missed in your cases. And otherwise, overall it was a good, I would say, yeah. Investigation, yes. So patient safety point and in your applied clinical knowledge point, if I consider your immediate management and few up and down of this, so I will give you borderline on your patient safety and applied clinical knowledge. Otherwise, overall, it was a good presentation, my dear.
Thank you, ma'am.
Thank you. Anything from your side? Any question? And here you can say this is from the talk. Few tables I have added to make sure how will you differentiate between the acute fatty liver of pregnancy, HELP syndrome, obstetric cholestasis, and preeclampsia. So only minor changes are there. So we have to see all the investigation very carefully what they have given to us. Then according to that, we have to make our final diagnosis. Okay, so for example, acute fatty liver of pregnancy, ascites, they have written, but in obstetric cholestasis, this is nil, it is nil. Thrombocytopenia, more in HELP syndrome, hypoglycemia, it is a feature of acute fatty liver. So this is mostly the differential diagnosis in this case. Otherwise, amino transferase like liver enzyme, here 5 to 10, here 1 in 100, 1 to 100. So mostly deranged in HELP and this thing, but here also mildly deranged. LDH, it is increased here in alpha fetoprotein, acute fatty liver of pregnancy. More than 600 here increased. Overall LDH increased because of hemolysis and coagulation derangement. It is increased in all cases. So here only we have to check here hypoglycemia. And if they are giving you male fetus mostly 3:1, 1:1, 1:1, 1, mostly in acute fatty liver. And recurrence risk may be in the exam, they will ask you rare in the acute fatty liver. Here 2 to 19% in the HELP, 45 to 70% as per this TOG article, obstetric cholestasis. Previous TOG it is showing 45 to 90, but here it is written 45 to 70%, 20 to 40% preeclampsia. So here 25% detect of fatty acid beta oxidation. So this is the flow
Ma'am,
chart. Yes, my dear.
ma'am, what point missing in patient safety? What should I
So,
consider more?
no, see,
What
patient
point?
safety, I would say, see, whenever we are asking about patient safety and apply clinical knowledge, always remember whatever things are applied clinical knowledge, these all points are added in your patient safety points. Okay. Like for example, immediate management, you directly went to the induction of
Delivery.
labor before stabilizing. So first we have to stabilize the patient. So you have to cover all the points in stabilization in A, B, C, D, E. If you miss word MDT also, it is one of the patient safety point. Like NSAID, you covered, I said. But if in case I'm telling you NSAID will come into patient safety point and into apply clinical knowledge point. Apply clinical knowledge and patient safety will run together. Only thing in patient safety, for example, your communication with the patient or your communication with the examiner. If there is no eye-to-eye contact, it will come into your patient safety also, it will come your communication point
Information
also.
gathering.
If anything, for example, blood group you missed in information gathering, for example, BMI you missed in your information gathering. But ultimately, if for example, patient BMI is more than 35 or BMI is more than 30, automatically it will affect on your VT prophylaxis, right? If patient
Yes, ma'am.
BMI is more than 35, automatically it will affect on your management, right? You have to pass
Mm.
IV line early. You have to arrange all the bed and cushions and everything depending upon the weight. You have to inform the operation theater that patient BMI is this, right?
Yes,
Allergy is
ma'am.
important. If you miss allergy in information gathering, but here it will affect on your patient safety. Why? Because if patient is latex allergy, then
Yes, ma'am.
so all these points are related with each other.
Okay, ma'am. So my problem is with I didn't stabilize the patient first. That I have gone wrong in
Yes,
both the
yes,
things.
yes.
Okay,
Immediate
ma'am.
management means what you will do immediately. And
Okay, ma'am.
justification. As I mentioned in the beginning, structure discussion means justification. Again, if you will not justify, for example, any of the point, it will not affect on your applied clinical knowledge. It will affect on your patient safety also.
Okay, ma'am.
So
Thank
here,
you,
see,
ma'am.
for example, this is your patient safety domain. Okay, if I
Mm.
go back, see, this is your what the examiner expect you to do. Focused history. So these all your history point. Interpretation and prioritization, focused examination, investigation you mentioned on, patient safety, immediate safety action, recognize that this is an obstetrical emergency, right? So ultimately, you have to inform your MDT, you have to stabilize the patient, then it is coming admit in a high dependency, maternal stabilization, insert IV cannula, IV fluids, checked correct hypoglycemia, which you didn't mention here in your point, right? Very
Yes, ma'am.
important patient safety point. Control BP if high. Give magnesium sulfate if severe preeclampsia is suspected. But anyway, this is, I mentioned overall, anything can happen in the exam, any scenario they can give you. Strict fluid balance and hourly urine output is very important. Continuous CTG monitoring, prepare for potential early delivery. So, continuous CTG monitoring, correction of hypoglycemia, mention that it is an obstetrical emergency, strict fluid balance, avoid fluid overload. These all important patient safety points. Correct coagulopathy, avoid NSAID. This you mentioned. Delivery after stabilization. Consider vaginal birth, anesthetic review. As you mentioned, anesthetic review. So differential diagnose, acute fatty liver. Why? Because my patient is having hypoglycemia, high bilirubin, prolonged INR, raised creatinine, moderate LFT rise. If it is HELP syndrome, so these are clue of HELP syndrome. If hemolysis,
Mm.
AST, ALT both are increased, severe platelets low, then my diagnosis will go towards HELP syndrome if previous history of high blood pressure also. Preeclampsia, history of blood pressure, immediate management, again stabilize mother first, MDT, analgesics, antiemetic, prepare for delivery. Decision for delivery once stabilized, definitive surgery or means delivery. Vaginal, cesarean if urgent or service is unfavorable. Correct coagulopathy, maternal risk you mentioned. Fetal risk if patients they are giving you scenario in the exam like 28 weeks, 30 weeks, 32 weeks, then yes, risk of preterm labor, risk of fetal distress, stillbirth. Postnatal again, these you covered. This I showed you, and this is your flow chart from the TOG article. Clear, my dear?
Thank you, ma'am. Yes, ma'am. Very much.
Thank you so much. Thank you, Anju, Michael. Who else are there? Anyone is having any question from the acute fatty liver? Aza, Devi, Atika. Anyone want to ask anything which is not clear? You want me to show previous slide? Okay, my dear. You can unmute yourself and you can ask me, no problem.
Madam, is this a previous exam question? Part 3.
This is TOG series, my dear, because see, nowadays I would say everyone don't completely rely on the recall and previous past paper questions. You should have a thorough knowledge on some important topic from the TOG articles. So that's why we from the RFA team, we have arranged these sessions for all of you to cover topics which we think it could come in the coming exams. Like HELLP syndrome. See, now last time it came migraine, Addison's disease, although Addison's disease is very rare, but they came in the last exam. So it means anything can come in the coming exam. So you people have a thorough knowledge, anything, any important topic, okay, which is usually in the common practice in our hospitals and clinics. So at least we should have a thorough knowledge on these common topics they can give you in the coming exams. That's why we have started this series, talk series, coaching sessions. Okay. Clear, everyone?
Madam, where would I be able to find this recording? Which part of the...
It is YouTube sessions, my dear. They will upload in the YouTube.
So I go to the YouTube channel, is it? Because I'm new, I'm sorry.
Yes. If you write in the YouTube this RFA, then you can write this acute fatty liver or today date. Automatically, you will get all the sessions on the YouTube. Okay?
Thank you so much.
Okay, my dear. Thank you. All the best. Next time we'll see you with another new topic. Okay, my dear.